Excellent. Thank you very much. All right. Good morning, everybody. So I lost this debate last year, so I'm hoping I'm going to do better this year. And last year would have probably been an easier one to win anyway. And actually, this will be easier to win, hopefully. So, hang on. Right. So the debate or the motion is obesity medications spell the end for endoscopic bariatric therapies, and I'm supporting the pharmaceuticals here. So can I just ask before we begin this, in the audience, how many of you agree with this motion? Raise your hands now. Okay. And how many of you disagree with this motion? Okay, so I think it's slightly in favor of the pros. So I've won already, right? Okay. Anyway, so I want to just give you some conflicts of interest, and luckily for me, none are relevant to this debate, which may not be the case for my opponent. So I'm a bariatric surgeon. I'm not a bariatric physician, and I'm not a bariatric endoscopist, and I don't get any honoraria from any of the pharmaceutical companies. But on the other hand, my very good friend Vinod is a different cup of tea. Here you can see him engaging in social activities with the Illuminati of bariatric endoscopy in the UK. So we know he's good chums with endoscopists already. And did you know that also he has published on bariatric endoscopic interventions? There you go, second author on this paper looking at cost effectiveness. We can ask him later whether he got money to write this paper or not from the company, but I'll let you ask that him directly. Also, he's been on the radio as well, talking about endoscopic bariatric therapies, so that's quite interesting. So, can one's objectivity sometimes be influenced by one's passion for a treatment? And I'll quote one quotation from the Bible, which is, Father, forgive Vinod, for he does not know what he's doing. Okay. Anyway, on a more serious note, ladies and gentlemen, there's no doubt that the landscape for obesity treatment is undergoing a seismic shift, not just in this country, but in the world. And today, I will argue a definitive position that the advent of these highly effective GLP-1 and related medication marks the beginning of the end for endoscopic bariatric therapies as a primary intervention. This is not a critique of their past value because they were useful, but I think going ahead in the future, there's no role for them at all. So there is going to be what I describe as a paradigm shift from mechanical to metabolic. So for decades, our options were limited. We had lifestyle options, invasive bariatric surgery, or endoscopic procedures that acted as a bridge. And then for these endoscopic therapies like gastric balloons, sleeves, ESGs, they basically work fundamentally in a mechanical way. They work by physically occupying space or restricting the stomach. The new generation of obesity medications like semaglutide and tirzepatide work on a metabolic basis. They target the hormonal dysregulation that drives obesity, including appetite and satiety regulation. So we're now treating the root cause of the disease, not just its physical manifestation. And this is a fundamental and irreversible shift in our treatment philosophy. So let's look at some data. I've summarized basically pretty much all the RCTs on these two treatments. In fact, I've also included surgery as well, given that the audience here is probably going to be full of surgeons. And I mean, it doesn't take a genius to basically, work out that if you're comparing ESG with GLP-1s, pretty much at every parameter, the GLP-1s are going to be, more effective. So if you look at the latest medications, they consistently demonstrate superior weight loss compared to endoscopic procedures. We're talking 15 to 25% total body weight loss with the dual and triple agonists also in the pipeline versus a ceiling of around 10 to 15% total body weight loss for many of the endoscopic options. But the real clincher is patient preference. Faced with a choice between a weekly injection or a daily tablet, which they can self-administer at home, versus a procedure that requires sedation, recovery, and the physical presence of a device in their stomach, the vast majority of patients will choose the medication. This demand from the patient side is impossible to ignore. And then the main thing, of course, is, obesity is affecting, 25% of our population, right? So we need to find a treatment that's going to be scalable. We need to reach out to the millions who need help. So this is about scale. And if you look at a worldwide basis, over 1 billion people live with obesity. How do we treat them? Endoscopic therapies are a bottleneck. They require specialized equipment, expensive facilities, expensive kit, highly trained surgeons or gastroenterologists. Medications, however, are infinitely more scalable. Once prescribed, any primary care doctor or online pharmacy, for example, can provide the treatment. So this allows much greater access to obesity care, moving it from the endoscopy suite to a doctor's office. We cannot end a global pandemic with a procedure that can only be performed in a handful of centers. So I'm sure Vinod is going to counter-argue these points, so I'm just going to put them down here already, so he doesn't have to mention them in his rebuttal. But anyway, he's going to say that the cost of the drugs are so expensive. So look, let's look at the high price of these drugs. And these will fall due to competition and eventual generics. And more importantly, the cost-benefit analysis is shifting as we see reductions in diabetes, heart disease, and other comorbidities. And then, thank you. And then the other thing about tolerability, no treatment is perfect, but the side effect profile of medications is manageable for most, and there's a preferable trade-off for many against procedural risks.
Thank you very much. Can't wait to hear enough from you all.
Okay. So anyway, that's the end of my argument. Yeah. Okay. Okay. That's fine. I don't mind. It's all right. My case is done. My case is done. So.
Okay. Can I have the podium?
Of course.
Can I have my first slides, please? Oh, yeah, thank you. So, chairpersons, colleagues, ladies, gentlemen. Firstly, thank you to Sanjay for putting both of us back on the stage again. I think, I'm sad that you've kind of stitched up Ahmed, but we'll see. So I have nothing against medications. In fact, I'm a fan of medications. I've got friends and family who are on medications. And on the right, you see my own handwriting. It's a script written by me speaking at a meeting abroad, talking about the positives of medication. On the other hand, I do believe in endoscopy, and the picture that Ahmed put up is very generous. It shows that I believe in a team sport, not an individual game. And he did not mention who this gentleman is he accused me of being pally with. It's his own bariatric endoscopic interventional gastroenterologist whom he has worked with for 15 years. There's been a bit of below the belt, so I was not going to say this. And I sit on the advisory board for Boston Scientific. Ahmed, not every relationships are transactional, so there's no financial gain. Now, as regards the management of obesity, remember the saying by Thomas Sowell, there are no solutions, there are only trade-offs. That's what we are faced here. So I think ESGs will be safe, effective, and scalable partners to obesity management medications, and they're not going to be a casualty. Ahmed spoke about all this. The NICE guidance very clearly places medications and procedures as part of a comprehensive MDT pathway and not on its own. There are problems with the rollout of medications, postcode lottery, all that. I agree, medications do work if people can start them and stay on them. But the problem is, look at this real-time data published in JAMA Network. Under 50% of type 2 diabetics stop them, discontinue them. And if it's non-diabetic, it's much higher. Look at the side effects. Even in well-controlled step trial data, there are side effects, and you cannot ignore them. Access issues, it's a huge problem. Manjaro and NHS, a very small number of patients get it. The cost, sadly, even today, we talk about real time, the cost is going up. It would come down, I agree. Everything in life, the moment it starts, it's high. It's going to remain that way, go up for a period of time. And you could accuse that medications are converting obesity into a wealth issue. That's where the EBT options come in. There are several of them. There are strong societal support. There's the IFSO position statement. Gerhard Prager is one of the co-authors. They looked at 15,000 patients who have had ESGs. There's a Venice Declaration of ESO. I'm really proud of this position statement from BOMS. This was produced when I was president. Look at the author on the right side. It's Mr. Ahmed himself. So either he does not believe in what he has said, or he has not taken his name off this publication, or taken this off the BOMS website. He's currently the president. There is support from the American Society, the support from the European Society, and the support from the BSG is just around the corner. Is it safe? There's data in the Lancet from the MERIT trial. For the balloon, yes, it's data from Birmingham. Look at the TOR procedure. Even now, Roux-en-Y gastric bypass is 30% of metabolic surgery. What happens to them? There is a degree of weight regain. TOR is a transoral outlet reduction, is a very effective method. Look at dumping syndrome and hypoglycemia. Once again, it's effective post-surgery. Gastrogastric fistula, traditionally surgical treatments been the answer, and it still is the best for weight loss. But for symptoms like abdominal pain, there is an endoscopic approach. Ahmed mentioned about this paper. Thank you for using that slide. I'm very proud of this paper, and there's no financial, I did not get a penny out of it. I wasn't expecting either. But what it clearly shows, he missed the point. It's a UK cost-effective analysis of ESG versus lifestyle modification alone. What about semaglutide and ESG? There it is. It's 3 times. Unless semaglutide, the price comes down by a third, there is no non-dominance, which means ESG is more cost-effective in class 2 obesity. The newest kid on the block, the old endo barrier, is a duodenojejunal bypass liner, the first case done at King's last month. We have been trained, and we are proud to say we'll be starting in Coventry next year. So what I'm going to suggest is, don't treat them in isolation, combine them. There's lots of evidence combining medication and ESG about TOR, and produces more effective weight loss and also metabolic control. Registry, I don't want to talk about, there's no international registry, there's no data at all. In the UK, 90 to 95% of patients procure this through online pharmacy or private sector, and 5% through the NHS. Even the 5% have no data about them. What about the 90%? So I hope one day we have a registry, but I think personally that horse is bolted. I think it'll be not for the medium, not for the long term. You will not have outside of trial data. But NBSR, every single surgeon in this room, I don't have the 35,000 that my good friend Mohit has, but I have 1,300 patients on my bariatric surgery registry, and all the data is documented. Very proudly, we got our ESG data as well on NBSR. And look at that, several centers, and this is the cut at the end of September. And if it were to cut on the 30th of November, there'll be more than 100 patients, and 25 or more would be ours as well. So my friend, I agree, medicines are transformative. There are problems with adherence, tolerance, cost, access. The lack of the registry is a huge problem, and there's limited coverage in the UK, at least as of today. What do EBTs do? They're evidence-based, they're safe, they're effective, they're guideline endorsed, cost sensible. There is data on NBSR, and there is expanding reach and durability. So I think we should join forces, we should combine, we should not compete, and the future is very clear. It is as well as, not instead of. Thank you. We got some rebuttal slides. So.
Back to you. You've got 3 minutes.
All right. So that's a very nice presentation, but you didn't actually answer some of the key points that I made. So it's all about degree of weight loss, improvement in health, and scalability. So you very nicely showed that you've treated 100 patients, or the units in the UK who do endoscopic bariatric therapies. But the issue is there's about 1 million people taking obesity medications. So if you want to tackle a global pandemic, do you really think endoscopic bariatric therapies are going to achieve that? I mean, you mentioned combination therapy. I have no issue with that, but I think at the end of the day, we're dealing with a disease that's affecting a lot of people, and we really need a treatment that's going to be scalable to a lot of people, and EBTs just won't be able to achieve that. So I think my case rests with the fact that you're just not going to be able to provide the treatment to the people that need it if you're relying on EBT or EBT plus medicine. Whereas if you just go with medicine alone, you're going to be able to offer it to a lot more people. And you mentioned, yes, in the NHS it's hard to get, but the numbers don't lie. 1 million people in this country are already on medications for weight loss. So I'll just end my case with my conclusion from my talk, which is the evidence is clear. You can see the new obesity medications outperform endoscopic therapies on the key metrics of efficacy, scalability, and patient preference. And they represent a targeted physiological approach to a complex disease. This is not a minor evolution, it's a revolution. While endoscopy may retain a niche role for patients who cannot tolerate medication or have unique anatomical needs, its time as a primary mainstream therapy for obesity is over. So long live medicines. Thank you.
Yeah, I've just got 4 slides. I don't think you listened to my talk. I was always talking about multidisciplinary and not that EBT will solve this problem. So, a lot of you were in this room exactly 12 months back when Ahmed and I debated whether medicine will finish surgery in 10 years' time. I know 10 years is a long time, but this is the end of the first year, which would be a pointer. Look at what NBSR has documented. And I'll go back a couple of years to show you what has changed. This is 2023. Yes, you've got private bariatrics trumped NHS bariatrics. Come to the end of March 2024, there's been an increase in the number of NHS operating. There's been a reduction in the number of private operating. This is the year that medications started being used. Come to the end of March 2025, the NHS bariatrics gone up, the private has come down by 50%. Look at the data as of midnight last night. So the counter hasn't reverted to 0 at the end of March, so you have to look at the difference. 2,700 NHS operations, about 600 private operations. So NHS operating in this country has gone up by 30%. Private operating has come down by 80%. This will be very different countries across the world, but I'm a surgeon, I do endoscopy, but surgery is my bread and butter, but the reality is that the average Joe public in the street, there is a better chance of him or her getting a bariatric or metabolic operation. The private sector has really suffered, which is sad, but I think it's about time the private sector, wakes up, smells a coffee and makes appropriate changes. So people, please don't be, put off by the fact that private bariatrics has gone down, the NHS operating has gone up significantly. Now, I think, as I said at the start, I am a fan of medications, and I hope that one day pharmacotherapy will have the bolt-on molecule that will maintain the weight loss once the medications are stopped. Ahmed, you need to do one of 2 things. You either need to get this off the BOMS website, or at least need to get your name off this publication. And I was really proud I'm still really proud when I was president, we got Boston Scientific, who are the endobariatric people, as a corporate partner of BOMS. And 2 years since demitting the post, I can see that they are still a corporate partner of BOMS, which leads one to think that you might not believe in endobariatrics, but the society which you really very well lead on as president still believes. So I would suggest that you might want to get this off the website if that's true, if your belief is true. You might not realize this, Ahmed, but you and I are in this phenomenally unique position where we are kind of, good professional voices in this field, And I think there are lots of colleagues who will always hear us. They might not always listen to us, but we can influence the fate of several thousands of patients, suffering with the problems of complex obesity. Let's not just divide, let's combine rather than compete, and work together and change the argument from one will kill off one another to as well as, not instead of. So thank you. I think my case rests.
Both sides. I'm a bit disappointed only to mention that the South Park episodes on injectable. I thought it was an easy win. But anyway, so let's have it. So who's for the pro? Raise of hands. Who's doing something? And who's for the against?
Well, thank you very much, both of you, for your excellent presentations. I think you have good points on both presentations. But I would like to ask you both. I mean, in my mind, there's no doubt that there is a
Can't hear. Put you on the mic.
Shall I? This one? Yeah. So, thank you both for your excellent presentations. Very good points on both arguments. There's no doubt that there is a shift in the treatment of obesity. It's not going to be a surgical disease in the future, that's for sure. But for me, the main issue is that medication, they work very well, they're quite safe. They will be more affordable in the future, and they will be available to everybody. But there is a significant percentage of patients, and please, Dimitri, correct me if I'm wrong, I think even with tirzepatide, which has the best weight loss so far, there's still about 20% of the patients that they have achieved less than 10% weight loss. So that is a significant percentage of a very big pie. And the question is that, what will happen to this patient? So I would like to have your views on that. And also, I think patients with high BMI, in my mind, there's no doubt that bariatric surgery will continue to be part of that, because combination treatment probably will give them the best. If you have a BMI 60 and you get tirzepatide, I don't think you will achieve what you will achieve with the combination treatment. So please give me your views on that issue. And if you expect that in the future, the medication, they will be even more effective, to the point that you don't even need to have combination treatment. So for me, these are the key issues. There's no doubt that medication, they're getting the momentum, but is it going to be still a room for a weight loss surgery? And more specifically for endoscopic surgery, there is demand. There is demand for whatever reasons, and I agree in a way with your point that it has to be part of the armamentarium to treat obesity, because there is demand for all sorts of reasons. Yeah, thank you.